PD. So these are my contents. So coming to the topic, as we all know, a tooth-supported processes obtain its retention from the abutment teeth. Whereas in the case of a tissue tooth-supported processes, it take the retention from both the tissue as well as from the tooth. So if we record that in an anatomy with an anatomic impression, what will happen? The tooth will get more force as the soft tissue will compress under the occlusal lock. So we should take a dual impression such that the soft tissue will be recorded under the functional state, whereas the tooth will be in the anatomic position. Today we'll be discussing about the different impression techniques in the RPD. Coming to the anatomic impression technique, this is recorded when there is ridges in a relaxed state or there is no occlusal force on that. So this will be indicated in case of tooth supported processes and class 1 situation. So a single impression will be done with a special tray, and that will be enough. So for the fabrication, we will be marking the extension of special tray on the preliminary cast, and we'll be adapting a spacer of 2 mm with a base plate pads, and a tissue stops are placed, and using the resin we'll be fabricating a special tray, and we'll take a final impression with a medium body, regular body, or elastomeric impression material. So for impression making, we should try the special tray in the patient's mouth. Once that is evaluated, and if it is correct, all the extensions are correct, we should load the tray and place the tray in the patient's mouth until the impression material set, and the impression is removed and checked for any kind of inaccuracies or imperfections. Then the master cast is after beading and boxing, the master cast is for. This is the anatomic impression technique. So this is the final impression and the final master cast. So coming to the functional impression, in this the residual ridge is recorded under some compression. So this is mainly indicated in the case of class 1, class 2. Then in the case of long span anterior edentulous class 4 situation. So a dual impression is required in such a particular condition. So a factor that influence the retention or support in a distal extension denture base is the quality of soft tissue and the amount of tissue covering the denture base, type of bone, and type of the occlusal force, amount of occlusal force, design of the partial denture, and fit of the denture base, and type of record material that we are used. So coming to the impression technique, it can be classified into physiological impression technique and selective impression technique. In physiological impression technique, the impression is done, all the soft tissues will be recorded under compressed state. And in selective pressure technique, the force will be, or the compression will be only given to the stress bearing tissue. So coming to the first technique, that is the physiologic method. In that there are two methods are there. That is McLean techniques and Hindle technique is the, then functional relining technique is the ridge correction using fluid wax system. The first one is the pickup impression method. That first one is the McLean technique. This was proposed by McLean. So it was like a custom tray is fabricated on the preliminary cast with an occlusal rim in the distal extension case region. So a wash impression is made by using zinc oxide, eugenol, or polyvinyl siloxane. And while taking this impression, the patient should bite on the occlusal rim. So this was the initial picture. So this was this is the special tray fabricated with a occlusal rim on top, and the patient will be biting on this occlusal rim while the impression is made. First impression is made. So after that, once the material is set, without removing the primary impression or the first impression, we will take a pickup impression with a stock tray with an alginate in it. So a finger pressure will be applied on the posterior region to push the first impression towards the ridge. to its functional biting position. The master cast is poured after beading and box. So, but there was a disadvantage in the technique because the pressure that we applied with our finger on the second impression will not be sufficient or equal to that functional displacement that is produced during the first impression. That was a disadvantage of this method. So this is the picture showing the final pickup impression, the first functional impression along with the pickup impression in the stop tray. This is the McLean technique. Coming to the Hindle's technique, Hindle and co-workers developed this technique to overcome the disadvantages of the McLean's technique. So they fabricated a special tray, only special tray without occlusal remnant, and they placed the took a wash impression. First impression was an anatomic one. Then they developed a stop tray with the holes in the posterior region, like this. A large hole on either side of the posteriorly to apply the so that the finger could able to apply direct force on the first impression during the while we are taking the pickup impression. And once that is set, we remove the both the impression, the first one and second one. A pickup impression is made and the master cast is poured after beading and boxing. So there was a disadvantages in this both McLean as well as Hindle's technique. That is, if the clasp retention is good, even though the patient is in a rest position, the tissue will be compressed in all the time. So this will cause increased bone resorption. And if the clasp retention is less, this will cause the tooth will be in slightly occlusally higher than the functionally recorded position. So this tooth will come in contact before the natural tooth. So this will cause some kind of premature contact, and this will cause discomfort for the patient. Coming to the next technique, that is a functional reline technique. This is done after fabrication of the framework as well as the denture base. This can be done after the insertion also. We will add a new layer. A relining is done after the fabrication of the process. So the procedure can be performed before the insertion or after a few days of insertion. So during the fabrication of the processes, we could able to place some kind of relief like ash metal or something is added during the before packing, so that there will be after trying in the patient, we could able to remove the spacer. So equal amount of space will be there for the impression material, relining material. Then we can also produce the space by trimming, but they won't that won't produce an even space in the for the impression material. So once that is done, after the fit is confirmed, the metal spacer is removed and a functional impression is made. How will you record the functional impression? We can use a lock using impression compound. It can be applied onto the edges as well as the ridge area and do the movements in a multiple times, and we will attain a border molding with an accurate impression of ridge. Once that is done, we have to remove the remove 1 mm of material, impression compound material from the ridge surface, so that we could able to record a wash impression using zinc oxide, eugenol, or fluid wax. So the amount of soft tissue displacement is controlled by the relief that is given to the green stick compound. Greater the relief, less will be the displacement. And the patient has to open the mouth or close the mouth. Patient has to in a such a state that the mouth is half open during the impression procedure to control the border tissues, cheeks, and tongue, and also for the proper placement of the framework. Once that is done, if the impression is made, we could able to pour the cast using altered cast technique. But there are few disadvantages for this technique. The first one was the While doing the relining method, we could able to change the occlusion of the prosthesis, and there will be a visible demarcation between the old acrylic and new acrylic, and it's difficult to maintain the correct position of framework while we are fabricating or making the impression. Next method is the ridge correction technique using fluid wax. In this technique, we are doing making the impression after fabrication of the metal framework, but before fabrication of the denture base. So once you are finished with your framework, just try that in the patient's mouth, and we'll be fabricating a special tray on the distal extension area in attached to the denture base minor connector. So a relief, once that is extensions are checked, we place that on the master cast, and an outline is marked on the cast for the extension of the denture base. Sorry, denture base, it's not denture base, the special tray. Then a relief is given with a base plate wax 1 or 2 mm. Then the cast is coated with separating medium, and using resin we fabricated a special tray in the distal extension area, and the tray is trimmed 2 mm short of the sulcus, and in the case of mandible, it should extend up to the retromolar pad and onto the buccal shelf area. In the maxilla, it should be extended up to the hamla notch. Now coming to the impression technique using fluid wax. What is a fluid wax? It's a wax that will flow under mouth temperature, and it will be rigid in the room temperature. So the tray, once the tray extensions are confirmed, the wax should be placed in a water bath of 51 degrees Celsius to make it fluid, and we'll be carefully painting that on the tissue surface of the special tray, dry special tray, and we will place it in the patient's mouth, and we'll use the ask the patient to do the border molding movement, and it should remain in the mouth for 5 minutes. Once that is done, we should remove the framework along with this special tray with the impression, and we should check for the accuracy. If the area, all the area come in good contact, that will appears to be glossy, and if there is lack of contact with the surface, that appears to be dull, and wrinkled area shows that there is inaccurate, insufficient time for the wax to flow. So once that is done, do the correction, again place it in the patient's mouth, reinsert it, and do the movements, and place it for 12 minutes. All the make sure the impression is perfect. Once that is done, remove the impression and pour the cast using altered cast technique. I'll be explaining about the altered cast technique in detail later. So these are the two physiologic methods. And this procedure, this functional ridge correction using fluid wax can be also done with low fusing green stick compound. And we can take an impression with zinc oxide, eugenol, or medium body elastomeric impression material. Coming to the selective pressure technique, it's somewhat similar to that of the ridge correction with fluid wax. Correction methods are somewhat same. So in this also, we are fabricating a special tray on the distal surface on the denture base minor connector, and we trim the buccal shelf area, trim very slightly so that direct contact will be maintained and more pressure will be transferred here. And the lingual slopes of the ridge also be trimmed, similar to the buccal shelf, so that it offers some support. And once that is done, we do the border molding with green stick compound. That is the after that we will make a wash impression with zinc oxide eugenol. So So if there is undercut in certain areas, we can also use that instead of zinc oxide eugenol, we can use a medium body impression material. Coming to the master cast. Now I'll be explaining about how will you pour the master cast. So for the functional reline method, ridge correction using fluid bags and selective pressure technique, all this method, it requires a method to pour the cast so that the master cast will accept the functional impression. So in that, first we fabricated framework, and once that is done, we fabricated a special tray as I discussed earlier, and that is now we took an impression using certain method. Now we have to place that impression, or we have to change the posterior region of that master cast into the according to the functional impression that we made. So we have to change the altered cast. We have to mark in the master cast buccolingually and anteroposteriorly. We have to place two lines. That is, see, this is the buccolingual line. Then this is the anteroposterior line. Buccolingual line will be 1 mm from the distalmost abutment, and it should be perpendicular to the ridge. And the anteroposterior line is perpendicular and parallel to the lingual sulcus. Once that is marked on the master cast, that portion is removed and retentive grooves are placed using a saw or something. Once that is done, the framework with the functional impression is placed on the master cast, and it is secured with a sticky wax. So this is the picture showing our functional impression that is sitting on the master cast, and the posterior portion is removed, and the impression is not making any contact with the existing master cast, and we secured the framework using sticking wax. Once that is done, we will be doing the beading with the utility wax and boxing with the boxing wax, and we will immerse that cast in a slurry. So for 10 minutes for the hydration of dry stone, and once that is done, we'll be pouring the cast with a stone with minimal vibration. Once that is done, after the material is set, we'll be removing the cast and we'll do the rest of the trimming, and the final cast will look like this, where the teeth are recorded in the anatomic with an anatomic impression, and the edentulous area, soft tissue, are recorded with functional impression. So this is the altered cast technique. So the longevity and success of a cast partial denture mainly depend upon the how the occlusal load is distributed. So in the case of a distal extension or tooth tissue supported prosthesis, we should consider a dual impression